Welcome, everybody, to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic is treatment of pain, opioid choices and issues for the patient and practitioner. And our speaker is my partner and co-owner of Optometric Education Consultants, Greg Caldwell. He's a graduate of the Pennsylvania College of Optometry, where he completed a one-year residency in primary care and ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutritional Society. Currently works in Duncansville, PA as an ocular disease consultant. His primary clinical focus is the diagnosis and management of anterior and posterior segment ocular disease, and he's been participating in multiple FDA clinical trials. He has integrated nutrition, prevention, and wellness into his patient care. Thus, he does practice integrative optometry. He is a co-founder of Optometric Education Consultants and co-administrator of a very wonderful resource, OCT Connect on Facebook. He has lectured extensively throughout the U.S. and over 13 countries internationally. In 2010, he served as president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 to 2016. And he's president of the Blair Clearfield Association for the Blind. So with that, it's our great pleasure to have Dr. Greg Caldwell talk about this pharmacologic dilemma and give us our choices for both the patient and the practitioner. So Greg, please take it away.
Hey, thanks, Joe. Thanks for the introduction, and thanks everyone for attending tonight. And real quick, we'll go through the disclosures. This is pretty quick here because really nothing I talk about in here should really be attached to any of these companies here. I don't put this list up here really to impress everyone. You know, I always say, how's a guy from Duncansville, Pennsylvania, had the honor and privilege to be able to speak to colleagues and, you know, and stay updated. And this is really the way, by staying integrated with the companies out there. No financial interest in anything here I talk tonight. You know, the PA medical director for Involve Healthcare Registries chairman. Really, the key here is the content was prepared independently by me. And if I mention anything tonight, someone asks something, there's really no proprietary or commercial bias or superiority being claimed here. So this is my practice. Again, I mentioned Duncansville, Pennsylvania. We own this building here. Yeah, I see patients Monday through Wednesday. And yeah, I like to always point out, you know, if you come to my lectures and you want to hear science and p-values and how we crush optic nerves and ganglion cells and so on and so forth, that's what you're going to get here, you know, especially with OEC. You know, there are some that are scientists and then clinicians. What we try to do here is take the science and blend it into something that you can use in your clinic and have a clinical application. So a little bit about, you know, myself and OEC here. I usually don't put the agenda in, but I put the agenda in here because you can either get this for pharmacological credit. Some states need this 2-hour course for their opioids and their DEA numbers and so on and so forth. So really, I put this in here as I comb through most of the states where they had DEAs, and just to see what their restrictions are, and you know, anywhere from how did the crisis and what's going on and the types of pain, in case you ever need to show this to a state board to see if you can get credit for it. So that's really why I put the agenda on there. And those are the things that we're going to cover tonight. So with that being said, I'm going to launch the first polling question just to see what's going on here. Is, you know, I'm taking this course because, and you could do multiple answers. I have a DEA license. I have a DEA license and it's required. I need pharmacology credits. I'm interested in the topic, or I will place my comment why I'm here in the chat box. So, all right, got hello from New Jersey here. Got some hellos. And looks like we're rolling in here pretty quickly. So good. We'll just kind of end the poll here, and Joe put the handouts in the chat box. So thanks, Joe, for doing that. And let's see, oh, good, 25% have a DEA, and it's required. Another 22%. Pharmacology, 55. That's usually it. And interested in the topic, great. All right, so stop sharing and let's see, someone wants in. There we go, and we'll get up for ready for poll 2. So this really isn't really our first opioid crisis. This is in the United States. It's actually our third crisis, and it always seems to be around, that, early part of the century where this occurs. The National Institutes on Drug Abuse, this is as of March, and this is when it all kind of really got going. And this is kind of why we're still using these numbers, because this is what they were using to really kind of focus on, was every day more than 115 people in the United States are dying from overdosing on opioids. You could see misuse of addiction to opioids, serious national crisis. Again, opioid misuse alone in the United States is at that time, $78.5 billion per year. You can see here again, 20 to 29% of patients misuse opioids. 8 to 12% develop an opioid disorder. Again, misuse of prescription opioids transition into, heroin or other types of illegal drugs. First used opioids, about 80% of the people who use heroin first used opioids. Overdoses increased, and large cities, there's been overdoses. So you can kind of see, this is where it kind of all stemmed from. So the HHS and NIH started working together in the summer of 2017. The National Institutes of Health met with pharmacological companies, academic research centers, and they wanted to discuss, safe, effective, non-addictive strategies to manage chronic pain. And you're going to see here, there's a big difference. Chronic pain, that's the ones that usually cause the issues. We as optometrists kind of get sucked into it because we have DEA. We pretty much manage acute pain, and we'll have that definition coming up here shortly to kind of show you. At this meeting, they wanted to do new and innovative medications and technologies to treat opioid disorders, improve overdose prevention and reversal of intervention, basically save lives and support recovery. So pain is important to our survival. So pain is not a terrible thing, right? We all had patients. I had this pain in my side, and I went to get it looked at, and they found a tumor pushing up against, an organ, and they were able to diagnose it early and to be able to remove that. So pain is not terrible, but when it becomes chronic and it's like lower back pain, there every day, starting to affect our lives, that's the type of pain that's out there, or pain from serious injury. So it gets confusing. That's out there. Pain is defined as a perception of a harmful stimulus. Pain can occur in the absence of injury or long after the injury is healed. That's out there. So pain comes from the somatosensory system. We have a diverse sensory system composed of receptors, processing centers produce the sensory modalities. So, I think we all remember, back in anatomy, touch, temperature, proprioception, that's our body position, and nociception, which is pain. And I just really love this picture here, just to kind of show you where, like our hands have a ton of receptors. Obviously our lips, this is kind of drawn to schematic. Our eyes, obviously our cornea being the most innervated per capita tissue in the body. You can see here that, pain is perceived, in the brain. And this is in a sense our pain center that we use. There's different types of receptors. We have those thermoreceptors. The ones that we're going to be speaking about mainly tonight are those nociceptors. And then, you can see the other receptors that are listed there for us. So Pain is an unpleasant sensory experience associated with actual or potential damage to the body or perception of such damage. It's a subjective experience. Memories of events associated with extreme pain persist for a long time, right? How many times did mom tell us not to touch the stove, or my dad told me not to touch the muffler on the tractor? It truly is hot. And we went and touched it, and then that hurt. And that reminded us, not to do that again, so that's part of those memories to help us, to not do that again when that happens. We also have that mental state is powerful influence over pain. We've all seen athletes, in sporting events get hurt, twist an ankle, and they keep playing until the competition is over, or maybe they break one of their bones or crack a bone. They keep playing, and after the game is over, they get X-rayed and they see that that they have, a broken bone. How many times have we heard of those heroic soldiers on the battlefield? They may get wounded, bullet wound, but they drag their colleagues off the field and save them, and find out that they've been shot. And again, how our mental, brain, pain is in the brain, and how the mental state can have a powerful influence over pain. So, pharmacologic ways to cover pain. We have basically tonight, what we're going to talk about are the peripheral acting agents. That's when you hear us, in a sense, talk about substance P working on the receptors, and we're going to be talking about the central acting agents, and those are the receptors. And a lot of times when I do this question or this presentation live, I get the question, where do anesthetics kind of fall into? They prevent the signal from traveling to the cortex. Those are signal inhibiting agents. I think a lot of you have seen me lecture with, Dr. Tracy Offerdahl over time, or at time on a webinar or at live events. She's great to listen to if you have never listened to her, but she's taught me so much. And, when it comes to pharmacology, it's always about the receptor, right? So the peripheral acting receptors, those are the ones that react to substance P, and that's what, the NSAIDs are targeting after. And then when we talk about the central acting, that's the mu and the kappas that are out there, and delta. So it's all about the receptors. If it's targeting a mu, kappa, or delta, that's our central nervous system. If it's targeting substance P and those receptors that are targeting substance P, then it's the peripheral acting type of part of the pharmacology. So, the system of inhibiting cells in the spinal cord, pathway for natural pain. Opioids that occur naturally as endorphins are important neurotransmitters in some of these descending pathways. So remember, pain is perceived up in the brain, and, we're just wired such amazingly. Like, how many times have we maybe, put our hand near this candle in this picture, but before we felt the pain in the brain, we were able to pull our hand away. It was kind of like, ouch, it's a delayed ouch. And the reason being is that, those receptors that are picking up that pain go through the spinal cord and say, hey, before you go up, let's contract that muscle, get that out of the way. It goes up, and then finally you get that, sense of pain. So, we're just wired amazingly here. And so, it goes up, and we have a descending pathway and an ascending pathway that's out there when we're talking about these different pathways. Peripheral versus central, we'll dive into this a little bit more. A lot of people think like, okay, central's the brain, but you're going to see that those mu, kappa, deltas are just scattered all the way throughout the body. But the idea is, they're saying that the opioids kind of work, if you're going to talk about in the brain, the mu and the kappa, but we do have mu and kappa in our lungs. We'll talk about that's how, that respiratory depression occurs, our intestines, how that's important. But when we're talking about the pain, we're talking about the mu kappas up in the brain blocking that. And then when we're using aspirin, that P substance, or if we're talking NSAIDs, non-steroidals like Advil or ibuprofen, we're talking more at the receptors that are out by where the injury is. So yeah, you can kind of think of it as maybe in the opioids, other than the side effects, that we're talking about centrally acting on the brain and the spinal cord, and peripheral acting about where the injury has occurred. So with that, I'm going to launch polling question number 2. And polling question number 2 is, what type of pain does not respond to opioids? Going to make it really simple. Is it nociceptive pain or neuropathic pain? Which type of pain does not respond to opioids?
And I think we're pretty good on the questions right now, Greg.
Perfect. And looks like they're rolling in pretty good with the answer here. So it's a little bit slower, but 2 choices. And I'll just end that poll and share the results. And the answer is neuropathic pain does not respond. So the nociceptive pain is what responds to opioids, and neuropathic pain does not. And you'll see why that's important later on into the talk here. So, for major, I'm going to highlight major, right? There's all kinds of pain that's out there. So nociceptive pain, typically as a result of tissue injury, inflammatory pain, the inflammation, inappropriate response by the body's immune system. Neuropathic pain, pain is caused by nerve irritation. And then we have functional pain where we're really, really not sure what's causing that pain. And so we just label that as, but there's different pains that are out there. Those again are the 4 major categories. So here's some nociceptive pain. This person says, I think I was hit in the eye with a tree branch. My eye is really hurt. I scratched my eye. It's all bloody, so on and so forth. He comes in with on a pain scale, he's about a 7 on a pain scale. It's a guy, so it's going to be a little bit higher number, right? So we take a look and start pushing some tissue around, and was able to kind of find the wound, and you can see we're kind of lacerated here. And he was hit with one of those trees that have a thorn on it, and it's cut right through the conjunctiva. We got some blood. Sure, he hit the sclera, and that's why he's pretty painful here with this. So this is nociceptive pain. So
Hey, Greg, just a real quick aside. Go back to the previous. This is not a opioid or pain question, but share with the audience, what's your thought process here? You can see it live better than we can. How do you know you didn't perforate and you're not just pulling a plug out of a balloon here?
That's a good question, Joe. I was, it was laying superficial, and when I grabbed it with the forceps here, it was just kind of laying on the surface of that sclera. So it wasn't like I had a tug and pull, and like kind of pulling a splinter out. I think the sclera did what it was supposed to do. I think it hit, being tough in the way it's kind of like Kevlar, kind of broke that off and just was kind of laying in that subconjunctival space. It was just loose in there. So it wasn't like I had to pull and unplug that. I probably would have thought different. And maybe even, obviously they're not dilated here, but if that was the case, dilate and maybe leave that one alone.
Yeah, because that looks like an organic throwing star there, and I can see how one end might, could easily penetrate the sclera, although the sclera is very tough. I just wanted you to share that thought process with the audience.
Yeah, luckily it was kind of movable in there. So So yeah, we got it out, and we don't have to really do too much with conjunctival lacerations. Cover them with some antibiotics, let that subconj heme go away. And this is a case where why it's in here is, we use some opioids on this patient for a day or two just to kind of help them out, get through this pain. So we'll talk about that. Remember, that was about a 7 for this patient, and you'll kind of see, as you heard me mention, Tracy and I at one time we're sitting around and we kind of made up a little bit of optometric, little cheat sheet for you to try and help out with that pain scale. So, pain is complex. It's confusing. We have nociceptive pain. We have neuropathic pain. This is a patient coming in here where this kind of gets a little bit confusing. These can be painful. And when those are erupting, that's kind of a nociceptive pain. And, they hurt. That's coming out through the trigeminal nerve. You have pain and so on and so forth. But then after these heal, after you treat this young lady over a course of about a month, you can see here, these shouldn't be hurting anymore, but later they get that neuropathic pain. They get neuropathic pain that can occur. So there's kind of 2 pains that can occur with these osteo. We always kind of talk about that neuropathic. We kind of talk about the neurotrophic, and then we talk about, the nociceptive or the harmful pain. So you kind of have it all here in a sense. She can have the nociceptive pain. You can maybe touch this when it's all kind of healed and touch both sides, and she might have a little bit of neurotrophic pain. One side is not as sensitive, but then there's that neuropathic pain where after some of these herpes where, you touch it or they get it on their arm, and even a silk blouse can cause them to have that neuropathic pain. So it can be confusing that's out there when we talk about all these different pains. I thought this one was kind of cool in chatting with her. Joe, let me know if I turned on the sound here. Let me know if you can hear this. If not, I'll share it real quick. Hi, everyone. I'm here with Helen. And as we can see, if you pull your head up there for me, we're just getting over some shingles here, some herpes zoster. And I was telling her about how it hangs out in the trigeminal nerve. And the trigeminal nerves, it's right behind, in a sense, the ear array here. And kind of show me where you were pointing there. You don't have to hold your hair anymore. Just tell me where you're having that pain.
Right here.
Yeah, right in there.
Right here.
And then tell me about you're having kind of things kind of shoot over. Tell me how you were explaining that.
Every now and then I'll be sitting and I'll get a sharp pain and I have to go like that, my ear.
Yeah.
And there feels like the whole right side of the back of my head feels like a numbing along the base of my neck, all numbing up through here.
Yeah. And that's exactly what, we were explaining is where this trigeminal nerve kind of hangs out. So she's healing up nicely. We're going to get her all healed up here, and she'll be back up and running. So thanks. So, that's, she started off with coming in till it was painful. Now she's getting numb. She's getting a little neurotrophic. She's getting the sharp pains. Now we're starting to get the neuropathic pain. So pain can be confusing, that's out there. And again, that's why we take these courses. Now, not to be confused, again, I said it a little bit earlier when I said neurotrophic, when I was trying to say neuropathic, right? So neurotrophic is actually a down regulation, right? And we show that a lot of the times in these pictures here, where this eye is more painful or sensitive than this eye with all the staining. We say that's, stain without pain. Why is that? I call this like stage, 6 dry eye on a scale of 1 to 4. This person is still got some sensitivity, their eye is watering, no one's doing anything about it. And basically the brain and the eye just says, you know what, if you're not going to do anything about it, I know this isn't good, I'm just going to down regulate. And so it down regulates, and now it becomes neurotrophic, right? So that's neurotrophic. we talk neuropathic, and we talk the nociceptive side of it. You know, and you guys maybe have seen this video where I show cornea sensitivity testing. Again, not that we're talking, this is the way it should feel. The patient will blink. As soon as I touch them with the fiber, they blink. And that's, you know, good pain sensation. But now this is not good. This is that kind of that stage 6 of dry eye. You can see the staining on their eye. They are not anesthetized. And literally, I tell them to blink whenever they can feel it. And I'm dragging that across. So just kind of working with some of the terminology tonight: neuropathic, neurotrophic, nociceptive types of conditions that are out there. And this is just another cornea sensitivity. And, you know, I'll show this one here that's out there again, you know, testing for that pain in the eye. You know, they can't even feel that. I tell them to blink when I do the videos, blink when you feel it. Now this one will start to blink a little bit because one of the fibers hits their lower lid and they can feel it on their lower lid. But again, down regulating, just kind of helping with all the different kind of terminologies and bouncing all those fibers off their cornea. They didn't really feel it. Oops. So the neuropathic pain, why it's important is that, you know, why is it irrelevant is that a lot of those are treated with these anti-seizure medications. They're working on the GABA system, kind of impairing, slowing down the transmission. Probably the most familiar that we know out there, gabapentin, which is Neurontin, and then we have Lyrica. And these are, in a sense, controlled substance in all 50 states, you know, and they have helped with this neuropathic pain. And the reason why it's important is because, you know, we're supposed to talk about, you know, ways to not be tricked, ways not to be bullied. And it comes down to is someone might come in and they might say, you know, hey, I had the shingles and, you know, I got this pain on my arm. I got this pain around my eye. I can't even, you know, touch it. And it's got all this severe pain. I've tried everything. And, you know, what really works, and I know what works, is Oxycontin. Well, you know, that's why you arm yourself with neuropathic pain, is that it doesn't really respond. That was the importance of that question. You know, sleeping medications out there, you can see that there's kind of on label now and some off label uses of how we treat neuropathic pain. But it's not ibuprofen, it's not Tylenol, it's not opioids. So watch out for those people coming in saying, you know, I have the, you know, the post-herpetic neuralgia, and the only thing that works is, you know, Oxycontin continuous release at this amount of milligram. You know, they're probably trying to get a, you know, be a smooth talker there and trying to get a prescription that's there. I think we'd all recognize that, but that's part of the course. So neuropathic pain, again, here's a nice little laundry list of neuropathic pains, and that is chronic pain. And they can be treated with tricyclic antidepressants. And I have the list here for completeness for us. Anticonvulsants, we talked about those. Anti-seizure medications, again, probably the biggest ones being gabapentin and Lyrica. And you can see Topamax makes that list also. So when it comes to pain, there's acute pain and chronic pain. And a lot of this addiction, a lot of these issues come from chronic pain. And this is where we as optometrists, you know, really just deal with acute pain. You know, the patients that come in with that lower, you know, back pain or that chronic knee or hip pain, you know, those are the ones that are just trying to get through life. And then things become tolerance, which we'll talk about. And then we start escalating into potentially addiction. So the good news is we have to take these courses at times. If you're taking this because you have as I think I remember, about 50% are taking this because they have a DEA number and their state requires it. And we're going to be using acetaminophen, NSAIDs, and opioids out there. So,
Hey, Greg, a question came in asking, do H2 blockers like Tagmet work for post-herpetic pain?
Yeah, that's a great question. I haven't heard that. Certainly can. Joe, have you heard that, or Arthur? I mean, you're asking, but sometimes, someone out there, or I can phone the audience here. We have over 100 people on. I've heard Tagamet maybe
I have
use it.
not.
You have not, yeah. I have heard it used for maybe colds that are out there, but not for pain. But it comes down to those receptors, right? If the receptors are there and they can start blocking that signal, then I would say maybe there's someone out there that it could be used for. So we used Tagamet in the 1990s in hospitals. There you go. So when it comes down,
I just did a quick search. It looks like it does.
yeah. So there we go. Tagamet for H2. We're working on some pathway out there again, blocking it and giving some relief to the patient. So when it comes down to pain, the goals do differ, right? So you heard me discuss Dr. Offerdahl, the pharmacist. She teaches at the optometry school, but she also has her own apothecary, and she does wears quite a few different hats. One of them is she is part of a pain clinic, and she gets to administer what the docs are prescribing. And basically, the goal for chronic pain is to keep the patient as comfortable as possible. And again, that's not pain-free, to allow them to be able, in a sense, to live a normal life, right? So that back pain, can you just ease it up so I can go to work, or I can walk, or, go to Disney and walk around? I might still have the pain, but I can still, do my everyday activities. Acute pain is to keep the patient as comfortable as possible while minimizing the adverse drug reactions from the pain medication. So that's why a lot of times in the hospitals, right, you'll see, on the whiteboards, or, like today's pain is a 0 or a 1, and they have the pain because that's more when patients are in hospitals, they're just there for a short period of time. In most cases, you're managing that acute pain. That's what we're doing as optometrists, is managing that acute pain, getting the patient through that acute crisis rather than chronic. And remember, back at the beginning of the lecture, where did a lot of this come from? Was that chronic pain, because of the tolerance that we'll talk about here shortly. So pain assessment scales, this adds an objective data to the patient's feeling of pain. It is a subjective problem to assess, right? So patient comes in pain, right? So, how much pain? So this is a nice way to do it that's out there. And I think let me just see what the polling question is. All right, let's launch it. Do you use a pain scale when prescribing narcotics?
I think we're caught up on everything, Greg.
Did it, Joe, in your research there, did it talk about that H2 blockers, what mechanism or what path it's working on?
The H2, they're blocking the H2 receptors. That's it. It is neuronal pain. It is neuronal pain.
So it's for neuropathic pain.
Neuropathic, yeah.
Yeah. Okay. Cool. All right. H2 receptors, neuropathic. Okay. Share those results, and yes, no, and I don't prescribe narcotics. All right, so we got 70% that don't prescribe me. We got 7 that do. We have the majority that when they do prescribe it. All right, good job. Okay, let me get this set for the next one. And I don't really keep my office with this hanging in on the wall. I have 2 computer monitors. Way back at that picture, you probably should have pointed that out. I run 2 computer monitors in my office. Every exam lane we have 7 rooms, they all have double monitors. All I do is just pain assessment scale, boom, hit Google, patients in pain, get them numbed up and say, okay, where were you on here? And this is a nice one to have because it covers, a lot of people understand 0 to 10. If they don't understand that, is it no pain? Is it the worst pain in your life? You can help walk them through it. Some people understand the smiley faces here. And you can see here that, some of the issues with these pain scales is, 4 to 6, moderate to severe, that's a difference of maybe how you would recommend your analgesic therapy versus being at this scale here. So, 4 to 6, 7 to 9. And, we come up with some suggestions here, a little cheat sheet, maybe a little nomogram that you guys can follow once we get to that part. So I thought this was kind of neat. I was watching, I think this is Baymax, a little older movie, but kind of scary how, with all this AI and different stuff that's happening now, Chat GPT. But I thought this was kind of neat in here. You'll see the part that I liked.
So, what have you been working on?
I'll show you.
Duct tape? Hate to break it to you, bro. Already been invented. Hey. Ow! Dude! Ow!
This is what I've been working on.
Hello, I am Baymax, your personal healthcare companion. I was alerted to the need for medical attention when you said, ow.
A robotic nurse.
On a scale of 1 to 10, how would you rate your pain?
Physical or emotional?
There you go.
I
Different
will
types
scan
of
you
pain
now.
using the pain scale.
Scan complete. You have a slight epidermal abrasion on your forearm. I suggest an antibacterial spray.
Whoa, whoa, whoa. What's in the spray specifically?
The primary ingredient is bacitracin.
It's a bummer. I'm actually allergic to that.
You are not allergic to bacitracin. You do have a mild allergy to peanuts.
Not bad. You've done some serious coding on this thing, huh?
Uh-huh. Programmed them with over 10,000 medical.
All right. So we watched enough of that. Let's see if I can skip to the next one there. So I like that because it points out a lot of things, right? I like the pharmacogenetics part of that. We're going in that direction, the part where, hey, I'm allergic to bacitracin. No, you're not. And that's where we're going with some of this opioid. Pharmacogenetics, in a sense, is going to be able to tell what people potentially are allergic to. But more importantly, for this lecture, that you might be able to tell which patients are going to be more likely to be addicted and to avoid that. And then obviously it was the pain scale that I liked whenever I saw this clip. So, drug treatment options when it comes to now, not neuropathic pain, but now we're moving over to the harmful pain or the nociceptive pain. We have non-opioids. We have acetaminophen, which is Tylenol. We have NSAIDs, which fall into your Aleve, which is naproxen sodium. We have ibuprofen. Aleve, and then your Advil, which is your ibuprofen. And then don't forget, your prednisolones and your methylprednisolones. Those are that non-opioid, taking away that inflammation, which, takes away some of that nociceptive pain that's out there. Then we move into your opioids that, in a sense, are codeine, and they could be by themselves or codeine with Tylenol, hydrocodone, for example, and tramadol. And these are kind of the ones that we're going to be using as optometrists. Codeine with Tylenol doesn't work real great, but your Vicodins and Ultram, probably if I prescribe, and if you're going to prescribe out there and you want to use it, which I would encourage because at times the adverse drug effects of Ultram, other than, the addiction, but we're doing it for acute pain, is a lot safer profile than say ibuprofen or at least ibuprofen. I won't go as far as Tylenol that's out there. So, okay, let me throw this question out. I guess we're going to be talking about the categories next. So marijuana is allowed in Colorado for recreational usage. Is it still considered illegal by the FDA? Yes or no? Marijuana is allowed to be used in Colorado for recreational use. I think there's other states too, but I know for sure Colorado. Is it still considered illegal?
And you're all caught up, Greg, in the questions? All is good?
Perfect. All right, got a nice response here. Nice little synchronous part to this. So thanks everyone for participating. We'll share the results. And we have 78 saying yes and 22% saying no. And the 78 are correct. It is still considered illegal, right? It's still considered type 1. It's that the state has voted and said, hey, the federal government, leave us alone. And the reason why I bring this up is because, when you step onto an airport, that's federal ground in a sense. So, I've seen people go to Colorado and get arrested and, they got all this, the sniffing dogs and so on and so forth. And then obviously if you land back into Pennsylvania, it's still considered illegal. So even though it's legal, in the non-federal buildings and parts of Colorado, where the state has voted and said, U.S. government, leave us alone, just kind of know what, property you're on when you're out there. So I just like to point out that, even though they're legal in these states, they're still illegal in a sense of the federal government, and the federal government doesn't go in and, and arrest the people there. The state is overriding that in a sense. All right, let me stop that. And so controlled substances, again, marijuana falls into here, right? We have medical, we have recreational. It's still considered as a Schedule 1, and along with all the other types of illegal types of narcotics listed here. Then we move into Schedule 2, and the idea is as you go down the schedule from 1 to 2 to 3 to 4 to 5, it's the less likely to become, addicted in a sense. So within Schedule 2, we have your oxycodone products and your morphines and your hydromorphones. And you can see that, I was president of POA in 2010. I served on the AOA board. And, we always said, look, we can be legislated out of things in our license. And that happened to me. I graduated, all I could do was dilate. And then we fought and got 2 therapeutic bills. One of them had a DEA number. We were able to do Schedule 3, 4, and 5. And the hydrocodone, Vicodins were in there, and they were moved from 3 to 2. And right there now is an example of how we were, legislatively moved out of our license, and we had to go back and, do that hydrocodone fix, which most states out there that had that, went for and did. So Schedule 3, again, as we get down, safer, the safest. This is all based upon the FDA rulings. Sometimes you do see they do go from a 3, to a 2 based upon what is happening out there once you start using the medications on masses. But Schedule 3 is considered safer, less likely to be abused as compared to Schedule 2. Same thing can be said for Schedule 4. What falls in this category, again, is Ultram. Ultram used to be a Schedule 5, and it then moved to Schedule to Schedule 4. You can see some of the benzos, as we say, that are out there, the diazepams, the sleeping agents, and then, basically your Schedule 5s are like your codeine that are used for coughs that are out there. So again, 5 being the safest, 1 being the illegals and most likely to be abused or create that addiction. So we
Yeah,
have
Greg,
that.
I think Schedule 1 is synonymously called the 60s.
Yeah, that could be. We could just call that the 60s or Schedule 1. So marijuana, again, is still considered C1, Schedule 1. We talked about that a little bit earlier and why that's important. The government just ignores it in those states. And again, we talked about 2014, how hydrocodone was a Schedule 3 or Category 3 and moved to a 2. And then states, I think one of the first states that were out there, or state like New Jersey, was able to get that fixed by legislating it back into the license. All right. So opioids, narcotics, it's a mainstay of therapy for the treatment of pain. And there's no maximum daily dose or limitation. And that's really what gets us into issues with the opioids, right? You'll hear me talk about, ibuprofen, 200, 400, 600, 800. And as you give them at different levels, you get different actions. Or aspirin, as I like to always talk about, 80 milligrams of aspirin. You maybe get the antiplatelet, but you really don't get much or any amount of analgesic. And then you give it a little bit higher, you get the analgesic, you give it a little bit higher, you get the antipyretic, and you have to give it a really high dose to be able to, get that anti-inflammatory. But there's a ceiling to those. If you give them, ibuprofen at 1,000 milligrams, 800 is really the max. It's just 200 wasted. You don't get that extra punch. The problem with opioids is, as tolerance builds, you have to keep getting them higher and higher to be able to get those. Well, you hear me talk about those mu and kappa and delta receptors, kind of covered to be able to reduce in a sense, the central. So I guess if you want to kind of think about it, is that the central system, there's no maximum daily dose, but then on the peripheral, there are some daily doses that are out there. And again, we use them for both acute pain and chronic pain that's out there. So, again, getting into some of how these mechanism of actions and how the narcotics work is that, you have the mu, delta, and kappa receptors. The mu receptor is the one, they all produce analgesic, as you can see here. Analgesic, analgesic, analgesia. So they all produce it. Now, when you tickle the different receptors, you get different things happening. So that's why, someone that's maybe taking opioid ends up with meiosis, because the mu receptor and the kappa receptors create meiosis. Now, the mu receptor is what creates the euphoria, right? That's that, that woo part that's out there. And the key that I like pointing out is, if you're taking an opioid and you get that little bit of woo-hoo, that's not saying that you are becoming addicted, right? That is part of the euphoria behind that. Your mu receptors are tickled and you took it for pain, but you're getting a little bit of a, woo-hoo. That, oh my gosh, I'm getting addicted. No, you're not getting addicted to that. Now that potentially could lead to, you want to keep getting that woo-hoo feeling, but that's not saying that you're becoming addicted, because the mu receptors. Again, I like using it. Sometimes a patient goes, oh my gosh, I was up all night, and if I could just get a good night's sleep, I know I can knock this thing out. That's like Pavlovian to me. Ding, ding, ding. What did you say? Good night's sleep? You're not going to go operate any cars or any bulldozers. When I hear that, let's get a good night's sleep. I don't mind prescribing the Altrams and the Lortabs to, the hydrocodone products. Now, with that, you have to be careful because of constipation. We'll talk about the respiratory depression. Now, the kappa, again, now give you the analgesic. You also get the sedation. Again, that's why if I hear that, also constipation, the respiratory depression, but then the dysphoria. I can't take this story, but Tracy can, and she came up to me. She goes, "Hey, I know you're a Disney fan, but," she goes, "Yeah, I got a sad one here for you. Yeah, I gave this opioid to a patient, and she was geeking out with me. She goes, their kappa receptors got a little tickled. It wasn't their mu receptors. They didn't have the euphoria. They had the dysphoria, and they were talking about basically how Mickey Mouse was chasing some chasing them or someone with like a cleaver. That's the dysphoria side of that." And then you can see here that delta is just all analgesic. So then there's different receptors, mu1, mu2, kappa, and delta. So when you look at this, you would think that why wouldn't they just make analgesics or opioids just target the delta and get rid of all the side effects? That would be a great thought, but the issue is we don't have that many delta receptors throughout our body. So we have more mu receptors, a little bit less kappa, and then the lesser amount. So if we were just wired a little bit differently, that would be perfect. And you can see here that we have the mu, the kappa, the delta, all kind of scattered, but we just don't have as many deltas scattered throughout this, if you want to say, central nervous system that's out there to help us out. Now, a lot of people feel that, the mu, the kappa, and the delta are just in the brain and the spinal cord. Well, they are if you're trying to block the pain. But the issue is that these mu and kappa fibers are found all throughout the body. So that's why when you give an opioid, right, I usually give Senecot S. I tell the patient, look, go pick this up. The drawback is that you're going to have to, take this stimulant and stool softener because it will slow down, the intestines from contracting, and it blocks it. And that's where the constipation comes from. So, Tracy, again, to steal her line is that, you can have the mush, but you better have the push, right? So you can just make a stool softener. It's just going to kind of sit there as a sludge. You got to have something else to get it. And that's the stimulant, the Senecot S. So really, anytime I prescribe, and that's just basically off of her training, but that's what she does when someone comes in, she says, "Hey, look, this is an opioid. Go down the aisle, whatever, and go grab some Senecot S because, it creates constipation." The other issue is that they're found in the lungs, right? And that's what kills the patient when it comes to, or, Michael Jackson, when he took too many opioids, and these famous people and non-famous people that take too many opioids to get that escalation, but it gets too high that it shuts down the breathing centers. So remember, the analgesic part, yes, brain, it's targeting the mu, kappa, and deltas of the brain and say the spinal cord to stop that pain from traveling up and down and getting to the brain. But it's the other side effects that are out there because of these mu, kappa, and delta fibers that are scattered all throughout the body. And you can see here, this was just geeking out, just all the different types of opioids and mu, and, you have some that have antagonist and partial antagonist or weak or no activity, just going through here and just showing the mu, the delta, and the kappa. These ones had the kappa, had no activity. These had strong activity on the mu. So maybe, these would create there's fentanyl right there, kind of that, that euphoria that could be out there. So opioid drugs that bind to the receptors, we have opiates, which are morphine and codeine. Those are basically kind of opioid, kind of original, right? Then you have synthetic, and then you have, or semi-synthetic, and then you have synthetic. So you kind of have the original, semi-synthetic, and then synthetic. And the morphine and codeine are your opiates, and then semi-synthetic or your oxycodone or hydrocodone, and then moving into your synthetic ones, and we hear about this every day on the news, right? Fentanyl that's out there. But then we have tramadol, which is a synthetic type of opioid drug that's out there. And again, if you want me to give you a clinical pearl, this is probably the one here that you'll be using most of the time. And that's kind of all the way up to about, say, your 1. I'm not sure if you need it on a 1, but let's say a 3 to about a 5-ish. And then from about 5-ish to about a 7 or an 8, you're going to be using your Lortabs that are out there.
Hey, Greg, there was a question that came in a little while ago about tramadol, and why was it moved? I guess the question is, why was it moved in scheduling?
Yeah, they thought it was not, because it was synthetic. That's a great timing of the question. Because of the synthetic part of it, they thought that, hey, it has such a loose association for abuse. It's not going to happen. We're going to make it a 5. And, throughout, just usage, it was being abused. It was being sold, right? You heard them called trammies at one time or whatever, out in the street. Hey, I need some trammies. So it's not as high as Oxycontin and fentanyl, but it was moved because of the potential abuse that was out there that was being done when they thought it was synthetic and not going to have any abuse. So great question, great timing. All right, formulations, immediate release versus controlled release. Again, going back and giving a clinical pearl, we as optometrists are going to be doing the immediate release type of formulations. Controlled release, those are basically for your chronic pain patients, right? So we're trying to take care of the hip pain, the back pain, trying to get the patient not pain-free, but trying to get them to where they can function. So they have usually tricky or nice names. I shouldn't say tricky names, but convenient names to try and point that out. Like here's one, it's Oxycontin continuous release. Here's morphine sulfate, continuous release. But when we prescribe them, we want to do, tramadol 50 milligrams or tramadol 50 milligrams a couple times, 3 or 4 times a day. Vicodin comes in continuous release. We want to make sure we give the immediate release. I'm not sure if any state is allowed to prescribe Percocet. There's probably a state out there that is. And then there's Tylenol with codeine. So again, we want to be able to get it into the system, get for that acute pain. Watch out when you're prescribing for the continuous release that's out there. Now, when it comes to checking the strength, morphine is kind of the comparison to other agents. So you'll see the ratios that are out there. So it's the standard for severe pain. Again, you can see here, it's, morphine sulfate, immediate release. If you're going to use morphine for an eye condition, you would use the IR, and you can see that there are just other ones that are continuous release. And in eye care, we would not be using continuous release. We would use the immediate release for these patients. Now, here, as you can see, why, hydromorphone is one of the strongest immediate release, or we know it as Dilaudid. It's used a lot, like in emergency rooms to help with the severe pain. It's very potent, and you can see here, 8 milligrams by mouth, you would need 30 milligrams of morphine. And that's kind of the comparison and how they use it out there. And you can see that is a very, very potent type of analgesic or opioid medication. The codeine base that are out there, we have codeine is again a category 3. You have hydrocodone, which is codeine based. It's a schedule 2, and then oxycodone. And I have this highlighted here in red. Again, we're supposed to try and help out with being tricked in these courses that some of you are taking this for your state licenses, not to be fooled. Why we take this course is that, you might have someone to come in and say, this codeine based, medication that I take, I know it helps with a cough. But that codeine's just not strong enough. Can you prescribe me some oxycodone that's out there? Well, even though it's codeine based, we're getting away now to more of the semi-synthetic versus the naturally occurring The naturally occurring suppresses the cough. When you get down to the semi-synthetic, it takes away that cough and the hydrocodone. But this semi-synthetic, because it's close enough to codeine in the structure and the organic chemical of it, it's more potent, but then it retains its cough suppressing. So, someone coming in saying, "Hey, I know that this oxycodone is, I just can't get rid of this cough, or I just need it to help suppress it." Well, there's no cough suppressant with it, so that's why I have that in red. So these are all your codeine-based types of opioids. Codeine tablets, again, it's a weak analgesic. You can see it takes 200 milligrams of codeine to get that, that standard, again, 30 milligrams of morphine. It's one of the weakest of the analgesics that's out there. I can tell you that it doesn't, in the clinical experience, it doesn't work really, really well with cornea pain, eye pain. So I don't use it that often. And they do make Tylenol 2, Tylenol 3, Tylenol 4. Basically, you hear T3 being prescribed all the time because it's really the best ratio. When we get down to some of the other parts of the talk here, you'll see that they switched Tylenol. It used to be 4,000 milligrams a day was the amount that you could give because of the liver issue. They dropped it down to 3,000. So if you give, 2 of these of the Tylenol 2 to get the 30 milligrams, now you got 600, and you can get to that, that 3,000 pretty quickly. And then if you're doing 60 here and you're only getting 300, it throws off the synergism. Long story short, T3 is used because you can give 2 of these. That gives you 600. You get 60 milligrams. It's just a nice balance. It's the best ratio that's out there. And again, you're not allowed to exceed those 3 grams of acetaminophen or APAP. So it's just the best ratio that's out there. That's why you see T3 all the time. When we move down to the oxycodone products, we have Oxycontin. Again, long acting. You can see that's extended release. You can see it right in the name there. Continuous release. If you're going to use it, if it's a state that you're allowed to use oxycodone, you're going to do, Oxy IR, which is immediate release that's out there. They do have it combined as Percocet. I think we know that one, where now you're getting the synergism, right? The synergistic effect of Tylenol, the analgesic side of that, the oxycodone that's out there, and you would take 1 to 2 tablets by mouth every 4 to 6 hours for pain. And you watch the limit of the Tylenol, that how many milligrams, at 3,000 milligrams a day. Obviously, you got to be careful with the opioid side because of the adverse drug effects, right? The side effects of the respiratory depression that's out there. So Percodan and Oxycontin and aspirin, not really used. That's basically, we put it in there for completeness. When Tracy and I were building this, sometimes we give this together and we put that in there just to say, okay, is there someone that might be allergic to Tylenol? Sure, you could do aspirin, but it's never really used. So how does oxycodone rank with morphine? Well, you can see right here, it's pretty close. You can see it takes 20 milligrams, which is showing it's a little bit more potent. So it's pretty potent compared to morphine. Obviously, it's very, more potent than the codeine, not as strong as the hydromorphone that's out there. So it's a nice analgesic, but now category 2 with that potential of abuse. Hydrocodone products, I think this is what a lot of the famous, out there. I think Prince, I know for sure, Brett Favre, he talks openly about it, the addiction to the Vicodin or the Lortabs. But again, as of August 2014, coming up on that 10-year anniversary next year, where hydrocodone was a 3, moved to a 2, and a lot of the states have gone and fixed that now. You have immediate release that are with ibuprofen, not really used that much. Pretty much it's this group right here, Vicodin, Lortab. And when I'm prescribing these, it's usually 5 5/300. It's 5 milligrams of the hydrocodone, 300 milligrams of the APAP or the acetaminophen. Again, depending on the scale, you'll see coming up here how we use this. This might be crossing into that 5s, that 4s. We're giving 5/300 or the 5 milligrams and 300. You start getting out to the 6s and the 7s. The 8s, you're giving now, 7.5 to 300. And remember, maybe towards the end of the scale, you could be giving some 10/300 of Vicodin or Lortab to help out with that. When you start getting a little bit on the other side of the scale, that becomes your hydrocodone products. On the left side of the scale, those are usually your Ultram if you want to talk narcotics, and we'll show here how we can use ibuprofen and Tylenol together. So here's a good one. If there's one slide you want to kind of star, you want to star this one here. This Tramadol, probably it's the one I use the most. It's pretty safe. A few little pearls here with the serotonin that we have to just look out for. But my go-to opioid when needed. Remember, it's synthetic. There are some out there that are extended. Watch out for Tramadol extended release, ER. ER does not mean emergency room. It's stronger. That's the extended release. Tramadol comes in 50 and 100. So I usually just prescribe the 50s. At the beginning of the eye problem, tell them to take 2 every 4 to 6 hours. And the next day or two, they're dropping down to 1 tablet every 4 to 6 hours. And you just don't want to exceed 400 milligrams a day. It does have that dual action. It touches that mu receptor, right? Gets that analgesic, but you start getting some of those other side effects. But it also inhibits the neuronal uptake of serotonin, which is good. That's what helps build it up. But there are people out there taking medications that are used to help increase that serotonin uptake. So the patients that are maybe taking sumatriptan or taking Prozac, be careful using Ultram as your drug of choice here, because that's a lot of messing around, for lack of a better term, with the serotonin that's out there. So anytime someone's on there, I usually just drop down to maybe a 5/300 of Vicodin. And again, it sounds like, oh my gosh, this guy's pretty cavalier. But when you talk to the pharmacists that are out there, ibuprofen scares the heck out of pharmacists, right? Especially chronic, acute, not so bad, but chronic, they'll say, it's not a matter of when if they'll bleed, it's a matter of when they bleed. So you got to be careful. We think, ibuprofen and Tylenol are safe, and you got people, take them every day and they destroy their liver, destroy their kidneys. We get a bleeding ulcer in their intestinal tract, somewhere stomach to their intestines. So, a lot of times when I talk with Tracy, he's like, heck yeah, feel free to do, as long as they're not on any serotonin uptake inhibitors and so on and so forth, blockers, feel free. That's a pretty safe medication that's out there. So we hear all this, we got to take these courses, we got to do this, I've got to be afraid. I'm going to tell you right now, people, please do not be afraid of these medications. Just understand them and respect them and use them appropriately. And you'll see that they do help out with acute pain in your practice. So with that being said, I'm going to launch this poll. So basically, you see a patient that comes into your office and they're on methadone. So every time you see a patient on methadone, you just kind of say, hey, these people are, recovering from some type of opioid abuse. That's the only use for methadone. True or false? That methadone is only used for opioid abuse recovery.
All right, Greg, couple questions have come in a little bit earlier. Is Cataflam still available?
Good question. I'll be one to admit, I'm not even sure what Cataflam is.
I think there's a form of diclofenac and NSAID.
Yeah.
And in the 90s was told to alternate Ultram with Benadryl to equal Tylenol 3 strength. What would be that mechanism?
Well, probably just synergism, just hitting different pathways, the Benadryl, getting up to the central nervous system, and Tylenol 3, not sure, these are the beautiful times whenever we need Tracy here for these lectures to be able to kind of figure out why they did that in the 90s. Maybe know why they quit doing it in the 90s and not really talked about much anymore. So wish I knew those answers.
I think you're all caught up.
All right. So the majority here, I would phone a friend, and false. That is correct. That's how I used to think. So I fell into that 40%. I'd see a patient come in on methadone and be like, oh, what's going on with this? You'll see why I talk about that here. I believe it's in the next slide. So these are kind of your miscellaneous types of, if you want to say opioids or narcotics. Let's get out of the way saying opioids because they're not opioids, but let's say narcotics. These are miscellaneous narcotics. Fentanyl, geez, oh man, we hear it every day on the news. If you listen to the news, I try not to turn it on. It's a beautiful part about XM radio, commercial free, right? So most potent opioid that's out there, or narcotic, black box warning. Literally, I asked Tracy about this. She's like, a black box pops up, literally got to cover everything in it. You're talking into the patient. You put your initials in, and the black box will disappear to allow the pharmacist to move on. So it's a true black box that pops up on the, say, in the computer screen here. And we have Demerol, and then we have methadone. And methadone typically is reserved for those people with morphine and codeine allergies. So that's, again, one reason why, someone coming in on methadone, they could be in a recovery state. And here's really the clinical pearl: once a day versus twice a day. So once a day is down here, or versus twice a day. If it's twice a day, they're probably using it for chronic pain, right? They're trying to just kind of keep them above that threshold where they can function. So they give it twice a day. They don't want them to dip down. The once a day is just tickling those receptors enough to stop maybe those receptors for saying, tickle me more, give me something different, so on and so forth. So basically, if it's once a day, it could be for chronic pain, but once a day is usually in the clinics. And then if you're trying to treat chronic pain, it's twice a day. And that seemed to have worked well over the years of me being in clinic. So we have analgesic medications for pregnancy, really simple: acetaminophen, Tylenol. It's the choice of pregnancy. You have all these different things out there: first trimester, second trimester, da 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 da. If pregnant, you want to do something for pain, Tylenol, no opioids. Really, really simple slide here to talk about that's out there. So opioid allergies, ask if the patient, if the patient states, and this might be where this is coming from, this Tylenol 3 and Benadryl, thinking about it now, it could be where this was coming from, because, if a patient states they're codeine allergic, ask the specific questions that's out there, because if they are, you cannot prescribe really any of these other opioids. Now, what happens is, if you take an opioid IV after surgery and they get that reaction, it's basically the opioid allows the histamine not to be released. And then there's a big release of histamine. And then sometimes you see these patients get the little blotches. So Paula, when you asked about that, maybe that's what back in the day, Ultram with, Benadryl, maybe that's what they're trying to do, is kind of get that kind of synergistic reaction and trying to maybe mitigate maybe some type of histamine release that's out there. But sometimes the people just are not allergic to opioids. They get that IV, they go into surgery, they get the blotches, and they go, oh my gosh, that person must be allergic to opioids, and it's not. It's from the histamine release. So, do you know what the patient can take if they're allergic to codeine or they have an opioid allergy? That's where fentanyl and methadone fall into play, along with meperidine here. All right, so let's see what we got here with another kind of little break here with a video.
I'm fine. On a scale of 1 to 10, how would you rate your pain?
That's an 8.
Hey!
Hot water, Mr. Smee. The poor captain has a splitting headache. We mustn't annoy him.
When I say go, push against my back, and we'll walk up the hill. Ready? Go.
Ow! You did that on purpose.
All right, I think we had enough of those. You see, that was kind of cute. Pulled that off of YouTube somewhere. Kind of, it's important to kind of know that numeric schedule. And so with that, this is what Tracy and I sat down and came up with one evening, is that, if you have 0 to 10 or this, 1 to 3 or 4 to 6, kind of using that for here. Mild pain, you could probably get away this 1 to 3. A 1 is going to be acetaminophen and your ibuprofen. And then you might get to a 3, right? That's the problem with these scales, is that you get to a 3, you might be moving into maybe a 50 milligram of Ultram. And then you get a 4 to 6, that's where you're moving into the kind of the mid doses, 50 milligrams twice a day, 100 milligrams, once or twice a day of the Ultram, especially if you're moving out to the 6. Your Tylenol with codeine, your acetaminophen with hydrocodone, or basically, I don't think there's a lot of states that allow Percocet, but there's a lot of states that have the hydrocodone fix. So maybe as you're starting to get out towards the 6s here, you're getting into that 5/300, or maybe that 7.5 if it's a 6 that the patient is waffling between like a 6 and a 7. And then when you move to the 7s through the 10s, you got Tylenol with your hydrocodone, again, your Vicodin, now you're moving into the 7.5/300. You have the 10/300. Again, a little harder for us to prescribe. A lot of these, especially if there are those, 8s, 9s, and 10s, the morphines, the hydromorphones, and the fentanyls, we're really kind of given the higher levels of Vicodin, 10/300, maybe, if we're going to try and manage that pain for the patient that's out there. So I forgot to reset this. So let's do this. So one of the main problems with an opioid is the low ceiling effect, the high ceiling effect, or the lack of a ceiling effect. Which one is it? Is it the low ceiling effect, the high ceiling effect, or the lack of a ceiling effect? I mentioned it a couple times.
And I think we're good, Greg. No, nothing else in the chat box right now.
Perfect. All right. It's like rolling in nicely here. I'll end the poll, share the results. And again, phoning a friend here would be true here. It's the lack of the ceiling effect, right? That's the issue with these medications. Not a low ceiling effect. I guess you could say a high ceiling effect, but there's no ceiling effect with these medications. And that's the issue. So the ceiling effect, when it comes to the central nervous system, this is the problem. There's no ceiling effect. The peripheral nervous system, we talked about that earlier, has a ceiling effect. The ibuprofens, the Tylenols that are out there, the more you give, it's just wasted. You get above 800 milligrams of ibuprofen, you give 1,000, it's 200 of it's wasted. But you could keep raising it, and then there's no ceiling effect when it comes to an opioid medication. So that's why we'll get into some of these definitions that are required. Tolerance is escalation of dose to maintain the analgesic or the euphoria. And this happens to everyone, right? So no matter who takes it, doesn't mean you're being addicted, so on and so forth. You take an opioid long enough, you will become tolerant to it. And again, it happens to everyone. So opioid effects, constipation, as I mentioned, we talked about this, it happens to everyone. So if you give Lortab, if you give Ultram, you give an opioid of whatever choice, Tylenol 3, just give Senna S, okay, that's the stimulant, right? Again, we don't want to just do a stool softener, just have the poop sitting in the intestine. You want it to be soft and you want it to be moved along. And again, to steal what Tracy says, you want the mush and the push along with it to help these patients out. You do get sedation. Sometimes that's good. Sometimes that's bad. You don't want them operating a motor vehicle. But if you have that patient that says, I just need a good night's sleep. Remember, the euphorias, the mu receptors, the dysphoria, the hallucinations are the kappa. So people are like, oh, I got a little hallucination there. What's going on? Those kappa receptors are being tickled. The histamine release, you get the itch. These plug into the barf centers of the brain, and that's why sometimes that's the codeine allergy. I got sick. No, they just plugged into the receptors that cause you to become nausea and vomiting. That's out there. That's not an allergy. Confusion, meiosis, right? Those kappa and mu receptors are found, in the muscles of the iris, creating the meiosis, and then. Again, this is what kills the patient is the respiratory depression. They're trying to get to that high, that euphoria, but the problem is they're trying to tickle the nervous system, but the respiratory system is shutting down. And then you have to be careful because a lot of the famous people that you're out there, you're seeing them taking opioids with alcohol or benzos or sleeping agents, and they're trying to do the up and the down and the up and the down, and eventually those lungs just get saturated and they just get shut down and cause respiratory depression. Opioid effects, adverse drug effects, withdrawal, the sweating, the agitation, the irrational behavior that's out there. And again, it's the respiratory side effects that kill these patients with these adverse drug effects. Now, this is how this works. This is how Narcan works. As you can see here, the organic structure here of morphine looks very similar to Narcan. The good news is it is strong enough to bump off that morphine off the receptor. So you have the receptor there, you have the morphine, you have the opioid sitting on the mu and kappa, causing the patient not to be able to breathe. They get the squirt of the Narcan up to the nose, it gets into the system. Good news is, boom, strong enough to knock off the morphine, and it allows the patient to be able to breathe again. And that's why it truly works that way. And you see the people wake up. And that's how that all works. The bad news is some of these new synthetic opioids that are hitting the streets, the Narcan is not able to knock off of the receptor. And that's why we're seeing a lot of rise in the deaths. These chemists in these illegal labs, in a sense, making these illegal drugs, don't want it to bump off to keep that high. And that's bad because if it hits the respiratory center, it's killing the patient. They try doing things from that way back at the beginning. We talked about the mixing or some of the meetings that occurred. So they said, well, how about we just kind of put the antagonist and the agonist together, put some of the opioid with some of the Narcan that's out there and mix them together. not really working real well, but a good thought that was out there in that outcome. Substance abuse history, who should we avoid? Avoid all opioids in patients with a history of heroin usage. This includes even using tramadol, right? The synthetic. I wonder if I can get away. They have a history of substance abuse. Can I use tramadol? No, don't use tramadol. May trigger the dopamine reward center and that need again that's out there. Stick with your NSAIDs and your acetaminophen. Also, what do you do if they're allergic, having a substance abuse to alcohol, amphetamines, the benzos that are out there? That's a judgment call that when it's out there, if they come in for acute eye pain, the good news is it's probably going to be a few days. Again, I would probably, if they came in having alcohol and amphetamine, benzo abuse, I would probably still avoid the opioids that's out there. We could probably use. It used to be called psychological dependence, and now it's true addiction. And true addiction is compulsive use despite harm, right? What that means is, there's some opioids on the side and inside this, this box where there's a bunch of razor blades and broken glass. And you know what? I still need the narcotics. I'm going to reach through that broken glass and razor blades, cut up my hand because I need that, that fentanyl. I need that, Oxycontin so I can grind it up. So that's compulsive use despite harm that's out there. And you'll kind of see a different way here that's coming up here where maybe they suck off the medication or the coating, or they use rubbing alcohol or just any type of isopropyl alcohol to get that coating off that you're going to hear me talk about. And they ingest that, and that creates harm that's out there. So true addiction is compulsive use despite harm. Identify those behaviors. There's people that say, oh yeah, codeine is not strong enough. I need some oxycodone out there because that's a codeine type of delivery. They're trying to teach you, fast talkers. Man, I'm allergic to everything that's out there. And yeah. The only thing that really works is fentanyl. Or man, I got all these allergies, but for some reason I don't have an allergy to, to oxycodone. Loss of medicines. Oh, doc, you won't believe it. The strangest thing happened to me today. My 3-year-old didn't know what they were doing. They flushed everything down, including all my narcotics that's out there. And the excuses again of why they need that stronger medication. Just avoid being bullied. Avoid acting like you're judging the patient. Use tools that are available. And that's why a lot of the states have these prescription drug monitoring programs. You can log on, type in the patient's name, see what's happening. You can enter it in there and see if there's the look for these monitoring programs that are out there with the state-based programs. I have an Oklahoma license. Here it is right here telling me, for information and integration, please click here. It's the Oklahoma Bureau of Narcotics and Dangerous Drugs Control that's out there. I have practice in Pennsylvania. Here's, the Pennsylvania, they just upgraded it, and I had to re-register or re-log in the other day. Again, the opioid treatment agreements went into effect, ensure a patient understands controlled substances. And you can see going through here, opioids, benzos, alcohol, so on and so forth. So these are state monitoring systems that we have to discuss during these programs. Ways to combat abuse. These are some of the things where the original form, you would crush it, and then it could be, injected and snorted and so on and so forth to get that high, to get those, mu receptors. And then they put on this gel inside, but then if you Google it, there's ways to get this off, and that's usually rubbing alcohol or isopropyl alcohol, but then that gets ingested, and then that's just not good for the body. So that's that, that use despite harm, compulsive use despite harm, that's out there. Sometimes you can just suck on it to get that coating off, let it dry, and then it turns into the powder that's out there. Another way here is that, the original formula, when you heat it up, you could draw it up into a needle and it would become liquid, and then you can inject it into a syringe. The new formulations, again, when you heat them up, they kind of clump up. You can't really inject them. Look, that needle's not filled. But again, there's ways around it using, again, things like rubbing alcohol, isopropyl alcohol, different types of, and then that gets sucked up into the needle, and then that gets injected into the body. But again, that's that true dependence that's out there. With despite harm, they'll still do that. So anytime we do these programs, we got to talk about alternatives and additions to opioid usage. So we're going to talk about NSAIDs and COX-2 inhibitors, and don't forget about those corticosteroids. And, we'll hit the highlights of, don't forget the alternative approaches of acupuncture and surgical interventions and nerve blocks and spinal cord stimulators that are out there. So now we're going to start covering parts of the alternatives. And I think one of the ways that if we want to talk about in a course like this, we could talk about using a bandage contact lens. A bandage contact lens, is a great way to control pain that's out there. And maybe pain, a bandage contact lens with ibuprofen and Tylenol might just be enough where you can avoid maybe using an opioid if you feel that there's risk there, or an opioid or bandage contact lens and Ultram. Medrol dose packs, they work well, again, as an alternative that's out there. You can see here, you're taking 6 pills a day. It's 21 tablets, 5, 4, 3, 2, 1. That can help out. And it's methylprednisolone that's out there, which is equal to 5 milligrams of prednisone if you're looking for that relationship. How strong is it? The prednisone, stronger than prednisone, as you can see, just slightly stronger, because you need 4 versus the 5. And you can see you're getting 30 milligrams on day 1 going down to 5 milligrams. So this is just thrown in here. I didn't take it out. Is there an alternative to methyl? Is there prednisolone? Yes. All in all, no one really uses it. If you're going to do anything, just do the Medrol dose pack. That's what's prescribed all the time. And that's the one that's cheaper for the patient. Adverse reaction to steroids. I think we all know the glycemic control. Basically, you can put this on just about every single medication that's out there. That every medication can really affect warfarin. That's why there's some new medications that are out there to take with food when you're doing steroids. Acetaminophen, really not sure how it works. We do know that it's good for mild to moderate pain, but it doesn't have any anti-inflammatory potential. And I'll get through a slide here where you can do synergism using ibuprofen and using Tylenol. So the mechanisms of ibuprofen, I think we know them as Motrin or Advil. Again, prostaglandin inhibition decreases inflammatory mediators, good for that mild to moderate pain that's out there. It comes in 200 milligrams over the counter. 800 milligrams is prescription strength. So that's why I always kind of talk, and you can give the patient 2 ibuprofen, 3 ibuprofen, or 4 ibuprofen. If you give 4, that's 800 milligrams. You're allowed to do that 4 times a day. So that's 3,200 milligrams. So ibuprofen, you're allowed to do 3,200 milligrams. That's 16 tablets a day of, if it's over the counter, of Advil. And then Tylenol, 500 milligrams, you're allowed 6 tablets a day. That's out there. That's the 3,000 limit that's out there. It's a good analgesic, or these NSAIDs. Aleve is very good. You can see available 220, 275. It's the same mechanism that's out there for ibuprofen. The adverse effects, make sure you take them with food. Again, tough on the stomach. When you talk to pharmacists, especially chronic patients, it's not a matter of if they're going to bleed, it's a matter of when they'll bleed. Vasoconstriction in the kidneys. Really, anyone that has diabetes should not be taking ibuprofen. It's really is hard on the kidneys. It's cleared through the kidneys, creates vasoconstriction, and then you have diabetes on top of it. Again, anything, you know, you can really put this on just about everything. Coumadin reacts with just about everything that's out there. Tracy and I wrote a nice little article a few years ago. It was in Review of Optometry. This is one of the tables that was in it. Basically, I think I have it right here, is summarized. There's your Tylenol. Used to be 4,000, now it's 3,000 ibuprofen. Here's what I do all the time: 2 and 2 or 4 and 2. It works really, really well. Sometimes, you know, if I'm out doing yard work and I tweak myself, I'll do 4 and 2. I like 2 and 2 for pain, because then the patient doesn't get it reversed. 2 Tylenol, 2 ibuprofen. I say to the patient, all 4 pills in your hand, in your mouth, swallow, take with food. Patients will say, I didn't want to do that. I took 2 in the first, and then I waited 2 hours, took 2 later. The key here is when you take 2 and 2 or 4 and 2, 4 and 2 gives you the anti-inflammatory. So the person that they hit at their eye, you know, pretty a lot of trauma, a lot of swelling I'm worried about, I'll do 4 and 2. I just want to make sure I write it down so they don't get 4 Tylenol and 2 ibuprofen. 2 and 2 I like, 4 and 2. If it's 4 and 2, it's all 6 pills into their mouth, take some food, try and get the stomach coated, but it's all at the same time. And the reason being, it's been shown to reach the level of morphine. That there is a study out there that shows when you do 4 and 2, 4 ibuprofen, 2 Tylenol, it gets to the level of morphine. It just doesn't stay up there as long as morphine. You know, it gets to the peak level, it goes up and comes down, might not stay there for hours, but it stays there and comes down, but you still have this high area. So that's why you want to take them together. In pharmacology, we call that synergism, right? That synergistic effect. I treat a ton of eye pain with 2 and 2 and 4 and 2. 4 and 2 I do is whenever I want the anti-inflammatory, if I think there's some inflammation going on. Another alternative would be CBD. That's out there. I have a whole 2-hour, Tracy, I have a whole 2-hour lecture on CBD and THC that's out there, but this is becoming more and more since 2018. It is now CBD, at least, is not considered an illegal substance that's out there. So, you know, but for 80 years, it's been illegal, but for the first 5,000 to 8,000 years before that, you know, CBD and marijuana was being used. It really wasn't that it was for lack of efficacy or safety. In 1937, Marijuana Act passes, and kind of funny, opioids come out very shortly after that. So, you know, talk about government stuff now. There was government stuff back then, and pharmacology and big business and small business manipulating and getting ways. So there you go. So there's THC, CBD that's out there. Again, it's a whole 2-hour lecture, but it can be used. The drawback is it doesn't work really well for eye pain that's out there. What you want to know if you're going to study this is the endocannabinoid system. There's different receptors, and we're learning more and more about this every year, since it's now allowed to be used and be studied and be used as an alternative. Again, the drawback is that it's not really used that much, or it doesn't have that much benefit for eye pain. THC drives the IOP down, CBD drives the IOP up. So there you are for glaucoma. Depending on what receptors you have, you might get a benefit, you might not get a benefit, but CBD by itself can drive the IOP up. So be careful with that. THC is what drives it down. So you see all these CBD stores getting about 40 milligrams can drive the IOP up. It's the THC that brings it down. If it's a CBD product, has a very little THC, not enough to drive the IOP down. So just be careful with that. It's the endocannabinoid system. And again, it's all about these receptors. So far, there's 2. I bet you they find 3, 4, and alphas and betas and gammas that are out there. So stay tuned to all of that. All right. So starting to see outcomes of studies with CBD. Remember, it was illegal. You're starting to see it in that fibromyalgia patient. Remember, that was that functional that we talked about, functional pain, really no cause. We're starting to see it as CBD full spectrum to be used with opioids. And CBD could significantly reduce opioid use to improve sleep quality, being used to decrease that reward center that's out there. So maybe used for the opioid drug seeking behavior. So lots of cool things happening with CBD. Just stay tuned with that. All right, so practical application. This is everything you need to know about prescribing really any medication. My point of putting this in here is that we also have to prescribe CBD in a manner as if it's a medication. And again, CBD does increase the IOP. All right, so our associations for hard. So what I always say in this last minute or two here as I wrap up is that I was on the POA board. I was sat on the AOA board for 3 years. I carry a DEA number because one, I do use it, but also when those leaders are out there and those volunteers are out there fighting, I would carry it anyway because that's just ways for medicine out there to kind of use that against us. So if you have a state that has a DEA, even if you don't think you're going to use it, prescribe it, because it really helps those at the volunteer or get your license, not prescribe it, but get your license, hold that license so they can show how many optometrists are out there in this era of opioid addiction and how responsible we are because we're not part of the problem. All right. In this last minute, let me just show you cases where I use it. You could use it on large burns, orbital trauma, blowout fracture, scleritis. Here's a patient here that was getting ready to talk to their daughter, turned their head, burnt their eye with a curling iron, a nice little S-char, a little well done, not even time for the eye to get red and inflamed. Well done epithelium right there. That was a time to measure it with the pain scale, figure out where they are, ibuprofen, Ultram, or Vicodin, depending on where they are, or a combination of all the other things, bandage, contact lens. I thought this guy was being a fast talker. He's like, yeah, I'm using this razor blade. Cut my eye really hurts. And I'm like, I really don't see anything until I saw this right here. And I'm like, oh, maybe there's something going on. These are the same photos. I'm not sure why I have it on there duplicate. Maybe it is a stereo disc, but basically, if you look right here, there's a cut. So I used my OCT, and you can see right here, well, he got pretty far down with that cut. About 407 microns, and it was about 600 microns about where they were. So he got about 2/3 of the way through. The cornea is very innovative, gave himself a nice little RK incision, and that's why this person was in pain. I'm not sure. This might have been an ibuprofen and Tylenol, or maybe an Ultram, until we got this kind of healed up for this patient. This patient here, this time of year, it was about this time of year, about 4 years ago. We do a lot of changing our own tires and working on our cars. And basically you could see a screwdriver, bam, right off of that, whatever he's trying to pry off his brake, boom, made a little LASIK flap. You could see the stain being pulled into the stroma, the endothelial cells, pulling it in. Pupil is not round, little hyphema. And luckily he didn't go as deep. I don't have the OCT on it as the other one, but it bounced off the cornea, and then he had a nice little laceration. The screwdriver went up under his eyelid. This was someone that got some Vicodin or some Ultram and covered this, with a good antibiotic, cycloplegic the patient because of the hyphema. There was a lot going on with this patient, but this was a one where I would use my DEA license. We showed this patient a little bit earlier where we got the thorn out of their eye. This was definitely one where I would consider some type of analgesic, whether it's the ibuprofen or the Vicodin or the Ultram that we talked about tonight. And I think this is the last case right here where this patient came in, their eyes in severe pain. It's like an 8. He went and had a DSEC procedure, never went and followed up and had a nice endophthalmitis by the time he came in and saw me. And I said, well, let's get you back to Philadelphia where you had your DSEC procedure, but I'll try and make you as much as comfortable, take away that eye pain. And the surgeon saw him that evening because he had to drive 4 hours or that morning. So we did give him a little bit of pain coverage to help him out. So with that being said, This is the last slide, and I'll launch the poll, see if there's any questions, Joe. I am now better
there's one
prepared to
last-
treat their pain.
One last question. Do you ever use these with ice?
Yeah, I guess, ice is a good to help keep the swelling down, help keeping things from leaking out. Maybe an ice pack if a patient brings it up, to make it part of my therapy. There's cold ice packs. There's sometimes they're in the freezer, you hit them. You could use it, but it's not really a mainstay in the therapy, but I like the idea. Joe, your thoughts?
Well, if it's inflammatory pain, yes, because ice is a vasoconstrictor, and that reduces the amount of fluid and inflammatory cells getting into the tissue. So almost always when you're wondering if there is inflammation, then I would have to say ice is kind of helpful for inflammatory pain.
Great. Looks like all the questions have been answered. With that being said, I want to thank everyone for attending. This was treatment of pain and opioid choices and issues for the patient and practitioner. This was a synchronous virtual course. Thank you very much for attending. This will end the education process.